CED Office Hour Live, where your Central State University Extension Community and Economic Development team has this platform where we talk about all things CED. And as I always do, I always like to give the definition of community and economic development, commonly known as CED, because it's like diversity, it touches on everything. But CED, community economic development work, looks at how we live, how we work, how we play, how we thrive, and how we navigate through all of the spaces, right? Such as infrastructure, which is affordable housing, it's building up community spaces, community buildings, private buildings, corporations, things of that nature, the actual physical highways, parks, all those kind of things. And then on the other end of the CED spectrum is the people development, workforce development, personal development, quality of life and access, equitable access, and we'll be touching on some of that today. And then the connector between the two are the businesses and organizations that help everyone navigate through those spaces, increase access, and things of that nature. And so here with us today is our CED team, Ambrose Moses, Eric Smith, and myself. And our guest today is the incomparable Lisa Sloan. She is the health equity expert, but she has done so many things. And I'm not going to take over the hour because I'm always excited whenever I get to interact with Lisa. So I will turn it over to you, Lisa, for you to give your own introduction and start telling us, after you give us a general introduction, tell us about your general journey as a small businesswoman, small owned, business company, how you got in your journey to even getting into the place where you are making impact in one of the hardest industries to make impact.
Girl, you have said nothing but a word right there. It is very, very difficult to be a business owner, especially a small business in the healthcare industry. Sales to healthcare organizations is such a challenge. There are so many ways that it's like, so many barriers that are in the way of success. So, they call many startups that are successful unicorns. We've been doing this for 8 years, and I would say we're a unicorn. Although we're not a startup, we are a small business. So a little bit about my journey. So I started my professional career at the American Diabetes Association in Pennsylvania. I was a lobbyist, and I was responsible for getting legislation passed that required insurance companies to cover the cost of supplies, equipment, and education for diabetes. And, that was, we got the legislation passed. Pennsylvania was the 22nd state to pass it. And it was very innovative at that time. And it was really health equity related work, but I didn't recognize it as health equity back then. And so I think that's an important point for, especially for the younger people on the call, because you never know how the work that you do early in your career is going to serve you later in your career or is going to benefit others. So I'll tell you a quick story about this passage of the legislation. So my mother, who is deceased now, my mother was a community college administrator. And at the time that I was working at American Diabetes Association, and we got this legislation passed. So my mom came home from work one day and called me, and she said, "Lisa, you would not believe the conversation I had with this lady today." She said the lady came in and said, she wanted to register for a class. She was an older lady. And I said, okay, so, what was she registering for? My mom said, well, more importantly, what she told me was that she was able to register because she had a little bit more money in her pocket than she had previously, because her daughter benefited from some legislation that was passed, and her daughter was diabetic. And so she was able to pay for her daughter's diabetes care through through her insurance as a result of the legislation. And my mother was so tickled by that. She told the lady, "My daughter did that." So you know how it is when a parent is proud of you. It's a moment you never forget. And that's one of my most precious memories of my mom, and how it, related to real life circumstances for individuals. And it just made me really proud of the work that I did there. So to fast forward, I ended up working at a federally qualified health center, a couple of jobs after American Diabetes Association. And myself and I was friends with the CEO of this federally qualified health center. Her name's Janine Peterson. She just retired last year. She's just a phenomenal person in the FQHC world. And so Janine had reached out to me and said, "Lisa, I want to write a proposal to CDC, and I want to write a proposal to HRSA to bring in some dollars to support HIV care and prevention in Dauphin County, which is where we were located in Pennsylvania." This is a good story for today because today is World HIV Day. And I said, "Okay, well, I was writing grants at that time, so Janine and I wrote these proposals, and Amber, those monster proposals, 80 pages. We were up taking those espresso beans from Starbucks, staying up all night writing these proposals because we both had day jobs. And she ended up getting both grants at the FQHC, and she called me and said, "I would like you to come and work on one of these initiatives." And so I did. I went to the FQHC, and we started the first HIV clinic for Black women in the Dauphin County area of Pennsylvania. At that time, they had the third highest rate of HIV in the state. So that was really important work for me because it was a Ryan White grant. And the Ryan White grants through the federal government require that organizations receiving the grants use electronic medical records to provide care to patients. And also it required that we have a continuous quality improvement component to our work. And so that's where I started to really understand the use of data to improve care for patients. We were able to show patients their viral loads and their CD4 counts in alignment with the medications that they were taking. At that time, we called them cocktails, so this was 20, 25 years ago, something like that, maybe even longer. And we were able to show them graphically how, Amber, did you see that notice that people were waiting in the lobby?
Mhm.
Okay, so we were able to show them graphically how their CD4 counts were impacted by the medications that they were taking, or their viral loads would increase if they weren't taking their medications. It was such a powerful demonstration for patients to see how we can literally look at your data. We can look at your test results. We can plug that into our EMR, and we can show you trends, about how you're doing when you're taking your medications, and how how your viral load increases when you're not taking your medications. Patients really responded positively to that. And so it was that kind of work that really was instrumental in pushing me to go to graduate school. So I went to graduate school at OSU, and then become really profoundly interested in how we could transform the healthcare system utilizing data and electronic medical records. And that would fast forward me to moving to Cincinnati. So in Cincinnati, the Health Collaborative had a grant from Robert Wood Johnson Foundation. It was called Aligning Forces for Quality. 16 communities were funded to um, to do these Aligning Forces for Quality initiatives, which were transformational in nature. And I got a call from Craig Bramer, who was the director of the program for the Health Collaborative at that time. And somehow he got my resume through the grapevine and asked me if I'd be interested in working on this AF4Q initiative. So I said, sure, I'll come to Cincinnati and work on it. I actually only had come to Cincinnati one time, and I went to the Aronoff to see the Lion King. And, I got to experience the neighborhoods in Cincinnati a little bit. And it reminded me of home because, we have a lot of hills and, vistas and peaks and valleys and whatnot in Harrisburg. And so, and a river life, which you have here in Cincinnati. And so I felt attracted to the city. And so I said yes. And it was on a contract basis. So, when you're working on a contract basis, a contract can serve as the foundation for building a business. And so I ended up building a small consulting practice around that one contract that I had with the Health Collaborative. And I ended up having some pretty decent contracts with had a contract with GE Aviation, which set the groundwork and the foundation for me being able to get other contracts. Because when you have a contract with a big name company like GE Aviation, others are feel that you have the credibility to work with them as well. So that really set the stage for some success with the consulting practice. So let me take a pause and see where you want me to go next.
Oh, you're flowing fine.
You want me to
So
keep going?
keep going. Yes.
Okay. And I
This is
just
your
want to
hour.
encourage people to put questions in the chat.
Yes.
Feel free to put questions in the chat to make this conversational. I think learning is best that way. And also I may learn something from folks that are out there in the audience. So
Yes.
definitely want to get people in the mix here and hear what others are thinking and what questions they might have. So okay, so fast forward, how did I get into health equity? How did I establish this company? So one of the things that I recognized in the Aligning Forces for Quality work was that if we were going to do this transformational work, that it was going to be humongous. It was going to be a huge lift. And there weren't enough people in the field to be able to educate the entire industry on everything that we had to do. We were working on data collection and data exchange. We were working on engaging consumers which is where the Consumer Council came into play, Amber. We were working on value-based healthcare. So helping providers understand how we could utilize different models of care to decrease costs and to increase the quality of care, which would result in a different payment mechanism for them. And then we were also working on quality improvement. So that was actually using data to understand the outcomes that we were accomplishing for patients. So, and remember, all of this was prior to the majority of the country's healthcare organizations adopting electronic medical records systems. So we had a lot of communications work to do, a lot of explaining to people, what we were doing and how we were doing it, and trying to recruit providers and get them on board. And so
Can we pause real quick on that,
uh-huh.
getting the providers? Because also what was a challenge that you overcame was even the work just to get the hospitals to talk, right? And to communicate and to share their data. Because a lot of times when you hear a hospital, they'll say they're the heart health center expert. They're number 2 in the nation. They're number 3, but they didn't share data. They all were so competitive with each other. So
Mm-hmm.
another important part of this work that you did during that time was convincing all of these major hospital systems. And in Cincinnati, most of those hospital systems are research-based hospitals. So they have a lot of different funding coming in, and very protective of their research and work as well. So getting them to bring in willingly the good, the bad, the ugly, and the indifferent data
Mhm.
into one place to benefit the whole region. I just wanted to point out how important that was, that work was.
It's a really good point. It's a really good point. And, I would also say that, for entrepreneurs, it's super important to understand the power of collaboration and the power of alignment with other organizations, especially larger, credible organizations. So, P&G, for example, had a high level executive that was involved in the aligning forces for quality work. And P&G was able to bring data to the table to say to providers, listen, what we know is that when consumers see that that their doctor is not providing or not achieving the same outcomes for their patients as other doctors are, they don't leave their patient, they don't leave their doctor. Patients have a difficult time leaving their doctor. They're going to stick with their doctor. And so it's most important for us to improve doctors' care outcomes because the patients are 9 times out of 10 are going to stick with them. And the reason this was important for providers to understand was because some of them weren't providing the best care, but and so they were afraid to show their data. They were afraid for it to be reported publicly. We ended up having 700 physicians that publicly reported the outcomes that they were accomplishing on 7 measures of diabetes care. And I mean, it's so important, such an important test of care, and test of change. And so that research from P&G, helping them understand it's going to be okay. If you share your data, it's going to be okay. It was super important for them to understand that, for them to trust that they could move forward with the publicly reported data part of the work. So, so as we move forward in the work, this was so cool. A lot, Robert Wood Johnson Foundation came back to each of the 16 communities and said, okay, you're doing great. You're doing public reporting. You're doing quality improvement, figuring out, how your care is looking for your patients. Now we want you to add an equity overlay to everything that you do. So, equity 17 years ago was often put on the back burner. And so Robert Wood Johnson Foundation, now they were funding these organizations to the tune of about $41 million. So when your funder has that kind of, change that they're sharing, when they say they want you to do something, you put your best foot forward and do it. And so in Cincinnati, I was charged as a consultant on the project. I was charged with advancing the health equity work in Cincinnati. So what that meant is, as a first step to improving healthcare disparities, we need to collect race and ethnicity data. That was like those are the basics. And I actually have that in my presentation, which I would like to share here. But that's a first step in the process. And so that was the first thing that we did in Cincinnati, was to teach our registration staff how to collect race and ethnicity data, and how to do that using what we call patient self-reporting methodology. So that means that the best practice is the gold standard is for patients to say what their race or ethnicity is, rather than, someone laying eyes on them and saying, oh, I think this person is this or that. So, that means that registration staff actually has to ask the patient, how do you describe your race, or how do you describe your ethnicity? So we trained about 1,200 registration staff at all of the local hospitals and the Drake Center. And Dr. Karen Bankston was at Drake Center then. And that was my first opportunity to work with Dr. Bankston, and we've been good friends ever since. So, Amber, I'm going to turn to the slides. Is that okay?
Yes, and after you get through your slides, I think that'll be a good segue to Ambrose's questions that he put in the chat. So I'll read those after you do the presentation.
Okay. All right. Very good. So I always like to level set on what health equity is. So we like the World Health Organization definition, which is that health equity implies that everyone should have a fair opportunity to attain their full health potential, and no one should be disadvantaged from achieving this potential. And then I like to get a little bit more specific because of the specific work that we do at More Inclusive Healthcare. So I like to define what health disparity is, because within that world of health equity, we're focusing primarily on health and healthcare disparities. And health disparity is a higher burden of illness, injury, disability, or mortality experienced by one population group relative to another group. This is a really important definition, and that last part of it, one population group relative to another group, is the primary reason why we collect demographic data, because we can't distinguish the outcomes that one group is achieving versus another group without the demographic data. So I wanted to share a few watershed moments that have really advanced the health equity movement. So the first was in 1965, and that's when the first federally qualified health centers were formed. We have about 5,000 federally qualified health centers in the country today. They're also called safety net healthcare organizations. You might hear the term community health center. So these are organizations that provide patients with care regardless of their ability to pay. They provide primary care, they provide dental care, they provide OBGYN services, and they provide pediatric care. So super important foundational work providing availability and access to healthcare throughout the country. The next really big watershed moment was in 2001 when this book called Crossing the Quality Chasm was written. So Crossing the Quality Chasm laid out 6 domains for healthcare quality. And the domains include patient safety, timeliness of care, efficiency, effectiveness, and health equity was one of the domains, as well as patient satisfaction. So health equity being one of the domains was important to shaping how we would advance in the quality improvement work that we do in healthcare. So with this book, it kind of became, like, we call it the quality improvement Bible in healthcare, because it sets the stage and the tone for what we would focus our attention on in terms of research as well as advocacy. And then the next watershed moments for health equity included under President Obama, the passage of the High Tech Act, and then the passage of the Affordable Care Act. So a lot of people, everybody knows about the Affordable Care Act, or better known as Obamacare, but a lot of people don't know about the High Tech Act in 2009, which provided the resources for health systems across the entire country to obtain electronic medical record systems. It truly revolutionized healthcare and provided us with an opportunity to accelerate our quality outcomes for all patients in the country. Along with that was then the Affordable Care Act. And under both of these acts, providers were required to say that they were required to describe how they were meaningfully using their electronic medical records. We call it meaningful use. And within meaningful use, they were required to collect race and ethnicity data. A lot of people didn't understand the impetus behind that, but the impetus behind it is that there is no identifying and resolving health disparities for people of color unless you have the demographic data. So there's always an excuse to not be able to say whether or not disparities exist. So, but once you have that data, there's no excuse. So you have the capability to advance your understanding of disparities that might exist in various aspects of your care. So in addition to these watershed moments, then we also have the Census Bureau data, which I'm sure everybody is familiar with, which shows us the changing demographics in the United States and the changing demographics of working age populations in the United States. So as those demographics change, that means that if we have disparities in care cost us a lot of money. I have a slide that shows the stats on that, but they cost us a lot of money. And they also cost us in terms of human resources, human life, quality of life for people. And so as we see these changing demographics and we know we have this tension of health disparities, it then becomes even more imperative that we address disparities in terms of the business case, which is the costs, and then the moral case, which has to do with our lives and our quality of life. So I wanted to show this statistic of disparities in care to give you an idea of what this data looks like at the national level. So you can see we have whites, Blacks, Hispanics, Asians, American Indians and Native Alaskans, Native Hawaiians, and other Pacific Islanders. And you can see that those that have reported currently having asthma, there's huge disparities. So 17% of American Indian, Alaska Natives report having asthma, and 12% of Blacks report having asthma. 10% of whites, 7% of Hispanics, and 5% of Asians. So you see great disparities between groups of patients. When we talked about the definition of disparities in care being based on groups, and that's what we're showing here. Same thing is true of diabetes, and then patients that have been told that they've had a heart attack. You can see disparities in that regard as well. And then, of course, most people are familiar with the huge disparities in COVID outcomes and COVID mortality. So I'm not going to get into the details. I actually have another slide on that. So here's the slide on the annual cost of disparities in care. $93 billion in excess medical costs, $43 billion in lost productivity. So translation, a lot of money. So this slide, I really like this slide from Kaiser Family Foundation, which explains it kind of breaks down and outlines health equity and health disparities into drivers of social and economic inequalities. So they have it broken down into economic stability, neighborhood and physical environment, education, food, community safety, and social context and healthcare system. And Amber, I really like the way that you introduced community and economic development, and how that correlates so closely with these domains of social and economic inequities. And so I circled this area down here: access to linguistically and culturally appropriate and respectful care and quality of care. Because of all of this health equity work that's going on, this is the little space that we're working in right down here at More Inclusive Healthcare. So that's, I wanted to point that out. So why do we collect demographic data in healthcare? I've talked a little bit about that. I like this quote from W. Edward Demings: "Without data, you're just another person with an opinion." Our data tells a story, and our demographic data tells us a story about the care that we're providing to those groups of patients. So that slide that I showed from Kaiser Family Foundation, it told you a quick story about care outcomes that we're achieving with various patient groups. So in order to get to that understanding and to get to those stories, we collect demographic data. And that includes data like race, ethnicity, and language, sexual orientation and gender identity, social drivers of health, and disability data. Those are some of the main categories of demographic data that we collect. We start with race, ethnicity, and language because we are most advanced in that data collection. Disability data is on the heels of race, ethnicity, and language. We're starting to collect more social drivers of health data, and some organizations are collecting sexual orientation and gender identity data. So all of these categories correlate with what we call health disparities populations. So these are specific groups of individuals that are likely to experience health disparities. So there are three considerations related to the collection of demographic data. And I like to talk about this a little bit because you say collect race and ethnicity data, initially you might think that's simple, you just don't think about it too much because, who thinks about that other than somebody that's working in the field? But once you get into it, you recognize it is immensely challenging. And it's so complex within the industry that, it's just a little bit unbelievable sometimes. But we try to accurately and consistently collect at least the race and ethnicity data at the point of registration. Just to add to the complexity, there are some things that we might not want to collect at the point of registration, like sexual orientation and gender identity data. So we probably want to collect that data in a more more clinical setting where the patient has more privacy. And then we also train staff in patient self-reporting. So at More Inclusive Healthcare 8 years ago, what I recognized was that we needed to have a consistent, reliable training to train staff. And then we also needed consulting that could help people in the industry accurately interpret the standards and the just the basics of both data collection and the categories that we utilize. I was going to talk about misinformation. So we have a lot of misinformation in the field, but also just misinterpretation because the standards aren't perfectly clear. So these are the basic categories of race and ethnicity, just to give you some indication of what you might be asked at the point of registration. So American Indian, Native Alaskan, you will recognize these basic categories from the Census Bureau. Asian, Black, African American, Native Hawaiian, other Pacific Islander or white, and then Hispanic, Latino, not Hispanic, Latino. So one of the things that I wanted to share with the audience today is that sometimes people look at these categories and they say, well, my category is more nuanced than that. I'm not just Asian, I'm Japanese, or I'm not just Black, I'm Jamaican. And they want to give a more nuanced category. And some health systems do have the ability to collect more nuanced categories, but some don't. And so, there are often going to be patients that are wondering, well, why can't we collect more nuanced data? And we are definitely headed in that direction, but it's going to take a while before we get there and we're able to accomplish that more nuanced data. So one thing that makes it more complicated is that I have up here the FIRE standards, 21st Century CARES Act. So in addition to collecting the data, so you see the data in this format, as words on a screen. However, we also have to code data. And in order to code data, we have to collect the data and we have to have the data in our system using a specific standard, a coding standard. And so that's where the FIRE standards come into play. The FIRE standards just went into effect at the beginning of, I think, the beginning of this year. And so as we get further into our depth in the FIRE standards, we'll be able to collect more nuanced data. But then we also have to get every health system and every healthcare provider in the entire country utilizing these same standards. And so why is the coding so important? This is important for entrepreneurs to hear. The coding is important because we are going to see a proliferation of apps and other types of resources for patients so that they can quickly access their medical data, their medical records, and other medical information. So you see Apple, you see Google all getting in the healthcare business, right? And you might have been wondering, why Google, why Apple? Because it's going to be a huge, huge industry. There's so much opportunity there. But in order for us to be successful with it, we have to get the standards and the coding right. Because in order to encrypt a patient's data, you have to be able to code that data so that no one can access the data and use it for nefarious reasons. Okay. So I'm excited about what's happening in the field, and I'm excited to help entrepreneurs know and understand some of the nuances and the difficulty, the challenges that we have with getting there. So how do we use
overdue? It is long overdue.
Yes, it is. So how do we use the data? We stratify it. So we take a quality measure, and I'm going to show you a couple of examples, and we group the outcomes by the demographic data categories. and that helps us to see the health disparities. How else do we use it? We use it to test interventions and to close those disparities gaps. So we're looking at the data not just as a moment in time, but then as a trend over time. So how are we do? So once we know there's a disparity in care, we have a chance to interrupt that disparity by utilizing some specific interventions. Like I heard about an intervention that Kaiser Permanente is testing related to people with diabetes, and they're providing people with diabetes with healthy meals, and they're seeing that gap in disparities between Black patients, Hispanic patients, and white patients start to close by addressing that one social determinant of health, and that is access to healthy meals and healthy food. And then coding data, which I just explained, is that we're using the data, we're encrypting the data so that we can then use the data outside of the walls of healthcare organizations. So here's some examples of health disparities. So this is people of color that had higher rates of infection, hospitalization, and death due to COVID. And Amber, I was just checking the time to make sure we have at least 15 minutes for Q&A.
We're doing good.
Okay, so you can see the way these are laid out is American Indian, Black, Hispanic, Asian, and white. So they're in order down here. So you can see our American Indian brothers and sisters that just don't fare well in any of these looks at the disparities that existed in COVID-19. And then in the case of our Black populations, we had lesser cases than American Indians or Hispanics, but we had an outsized number of hospitalizations and deaths as well. Hispanics. So for our Hispanic populations, I mean, there are just some heartbreaking stuff that happened with Hispanic people, especially those that are working as migrant workers and in meatpacking facilities. We looked at some data in North Carolina where, there was, I don't have the exact stats, but, it was something like the Hispanic population made up something like 15% of the population in the county, but they accounted for 50% of the COVID cases, which is, just a disparity that is unimaginable. So this is what the data helps us to understand. And, here are our pregnancy-related mortality rates. So, the heartbreaking rate of mortality experienced by Black women is just, it's unspeakable. We have third world countries whose rate of mortality among Black women is, among all women, is not this great. So it's just unbelievable. And again, our American Indian, Alaska Native individuals birthing people, not good. But this statistic, this was 2016 to 2018, and it's worse. It's gotten worse through the COVID years, not better. So what one other point that I wanted to make regarding this data. So this is national data, and the way that we get to interventions and solving disparities problems is at the local level. So where we have this national data is all well and good, but until you look at the data at the local level, so until TriHealth looks at their data, until um, Mercy looks at their data, and St. looks at their data for a wide variety of quality measures, we don't have the opportunity to identify these disparities and resolve them. And so that's why I've been able to make a business out of helping healthcare organizations collect their data and then start utilizing that data to identify disparities in care. So I'd share that we're just at the tip of the iceberg in this work. I've been doing it for 8 years. You know, Amber, I could talk about how I was able to succeed in my first 6 years. Had the 2 COVID years were hell.
Mm-hmm.
Last year, with this year, last year, you know, started to improve at the end of the year. This year has been a really good year, and going into 2023, we are looking solid. You know, everything in terms of our metrics is going up in the right direction, and I'm feeling very good and positive about where we are and prepared to help these healthcare organizations. One of the reasons why is because the current administration, federal administration, has put a real emphasis on health disparities and improving outcomes for populations that experience health disparities. CMS has put a lot of resources into disparities resolution, and they have really emphasized the collection of race and ethnicity data, and they'll move on to disability data, and then sexual orientation and gender identity data. So, I mean, it's a long trajectory, but we are off to a really, really good start. You know, we've had various administrations do a lot of work toward the effort. So we had the Bush administration actually did an outstanding job of laying the foundation for data exchange.
Mm-hmm.
It was important that that happened. The Obama administration was able to pick up that mantle and advance the work through the HITECH Act by introducing EMRs into every healthcare organization in the country, and then shore up access to care through the Affordable Care Act. Super important. And then we'll skip to the current administration, where we now have an administration that is working hard to utilize data and pushing healthcare organizations to collect and utilize data to identify and resolve disparities.
So with that being said, since we're talking about disparities and just knowing how you were, that's why I said I already knew Ambrose's question would be a good segue. So Ambrose, if you want to read what you kind of put in the chat, you had a couple things, but start with the first one regarding racism as a public health crisis, and then we'll go from there.
Okay. Yeah. As the question was written, in 2020, several of the cities and the counties across Ohio and also in other states declared racism as a public health crisis. And I just wanted to know, get your take on what does that mean, and then how has it impacted the work that you do currently, and then going forward, how do you anticipate it, impacting the work that you do?
Right. This is a big question. So I would say that COVID-19 combined with the murder of George Floyd really forced an unveiling of health disparities in the country. And I would say that health disparities have been a public health crisis for a long time, but we couldn't really even say the word racism, in healthcare environments prior to COVID-19. And prior to the protests related to George Floyd were instrumental in advancing the conversation, forcing the conversation. No one could turn a blind eye. And, we had white coats for Black Lives, which was a drive by providers saying basically enough is enough. And, we recognize that there are health disparities and we want to do something about it. So, and then I would also say that there's utility in this phrase that that racism is a public health crisis, because I think that people believe that disparities exist because of one's race or something that individuals do in their lives. And it's not about race. Race isn't the public health crisis. Racism is the public health crisis. And so the isms, yes. And so the making the language clear, I think was an important, I think it became an important rallying cry to point out that there are disparities in so many aspects of care, of healthcare, and so many aspects of us living our best and healthiest lives. And I think that is that's the main, those are the main points and utility. It's a rallying cry, it's a clarification, and it's signifying, that it's time for us to do something different.
But you made a number of references. You talked a lot about the data and the importance of collecting data, that you can't make certain decisions if you don't have the data, to show these things. So is it in terms then of going forward, and the cities, the counties, the community-based organizations being able to take certain actions, is that where that data comes into play then, being able to use the data and use the declaration by the city councils and the commissioners to now do some things that they couldn't or wouldn't do before?
Well, I'm not a public health expert. My expertise is more in the delivery of healthcare. There is, from my perspective, so let me share this. The accrediting organizations for health systems and for health plans are driving uptake of health equity and improving health disparities. So one accreditation body is called NCQA, and NCQA is requiring health plans to report patient satisfaction by race and ethnicity. And they are signaling that they are going to have greater expectations for health plans. This is all new. This is all new work within the last 2 years. And they are signaling that they are going to require additional measures of quality be stratified by race and ethnicity first, and then sexual orientation and gender identity, um, so that disparities can be unearthed at the health plan level. And then in turn, the health plans are looking to providers to also improve their care outcomes and start to utilize their data. And in addition, the accrediting body for health systems is one of the primary accrediting bodies is called Joint Commission. And the Joint Commission is now requiring every health care organization that they accredit to have a plan for addressing inequities in care. And in order for them to have a plan, they have to have the data, and they have to demonstrate that they have it and that they're starting to use it. So that is how we see it playing out at health plans and health systems. We also have examples of like we're working on a project in Massachusetts. So Blue Cross Blue Shield of Massachusetts decided that they are going to publicly report disparities in care. So they have probably 30 measures of quality that they grouped by race and ethnicity, and they have it publicly reported on a website. So you can publicly see disparities that exist among the patients that they care for. And then, which I think is super impressive, that they put some money behind their work and partnered with the Institute for Healthcare Improvement. And now they have about 15 health provider organizations, so health systems and networks of physicians, that they awarded $21 million to initiate health equity projects within their organizations. And all of them are focusing attention on this data, race and ethnicity data collection, so the demographic data collection, and utilizing that data to improve disparities in diabetes care, in hypertension, in maternal mortality, and all those really elevated, visible ways that people of color are impacted differentially from other populations.
Thank you.
You're welcome.
So, are there any other questions or anything from the audience? And Shashanda's typing something. So while she's typing, one of the things that I that I find very um, important in your work, and that you constantly do, is keeping the output and how it impacts the patient, right? The human beings, right? Because a lot of times when you're dealing with data, people get so caught up in the numbers, they forget to humanize the numbers. So I just want to say thank you for making sure that you keep us people at the forefront in all that you do, and have those conversations. Because when you deal with scientists and researchers, and that's all they do, they're on the numbers, what does that test say, but not the impact really on the human, besides the physical and the quality of life. So I just wanted to make that comment.
Thank you, Amber. And I did want to say, I should have said this 5 minutes ago, but I forgot. In 2023, we're going to be introducing a certification program. So we're going to be certifying individuals to teach implicit bias education in the healthcare industry. Something that I am so thrilled about, and we have really phenomenal resources that we've developed. It'll be turnkey. So after a person goes through the certification process and they're certified, they will not only have a credential, but they'll also be certified to utilize the materials that we've created to teach about implicit bias and to interrupt implicit bias in healthcare. So that's something that I wanted to share, and I'd like to come back and talk about that when we have that certification up.
When do you think it'll be up?
We're going to
That's
pilot
music to
it.
my ears. So
We have five people that we have tapped to go through the first certification round.
Mhm.
And so we want to get those people through the first round. That'll probably happen by February. So we should be ready for the broader certification program in March.
Okay,
So
so that's music to my ears because March is the next month that I have for scheduling of the show. We rotate who has each month. So March is my month, and it's actually Women's Month. So I will be focusing on women-owned businesses. So let's talk, and I'm penciling you in for March. So um, as long as your schedule allow. But I
I
think
love
Ambrose
it.
had something to say.
well, to that point about the implicit bias, and you might not have an answer today, so we will look forward in March. Um, in terms of the state of the research with implicit bias, does it impact? Can you quantify that it impacts decisions that are being made and actions that are being taken by, let's say, police officers, prosecutors, judges, and others? I mean, you're talking about in healthcare. And the reason I ask this is that I was listening in on a hearing that the city council, Columbus City Council had, and they were talking about implicit bias. They had all these studies, and the expert or the person speaking seemed to sort of hold back and say it's inconclusive whether the implicit bias can be shown to be impacting the actions of police officers, because they were talking about police brutality. And my gut feeling, just as a layperson, would be that it makes sense that it does impact those decisions and actions, but the establishment would not want that fact to be known, because if it does, then it sort of undermines, not even undermined it, it shows the fragileness and the inequities of those structures, those institutions. So it's like willingly just covering your eyes, saying, well, that's not the cause of why this is happening, when it seems to be obvious that it is, and they don't have necessarily an answer.
Yeah.
um
My opinion is that when people are resistant to accepting the concept of implicit bias influencing our decision making, is for two reasons. One is it primarily is fear of the consequences. And second is a lack of knowledge about what implicit bias is and how our various biases impact our behavior. All of our behavior is impacted by our implicit bias. And we can, there are certain things that we can look at and say without any reservation that there's implicit bias. An example is in medical records. So there was a study that came out recently regarding the ways, the words that physicians use to describe various patient populations in their medical records. And there was no question that there was implicit bias toward Black people. Absolutely no question. So we can look at those kinds of examples. And I don't look at research related to law enforcement. So I don't know. I can't state anything about the research there, but I feel pretty certain that there are going to be examples, things that have been studied, where you can say conclusively that there is implicit bias involved in the decision making. I mean, the hardest thing about implicit bias is, the first thing is understanding that we have it. The second is understanding how we operate as in our in groups. We have in group favoritism, and that combined with our type 1 processing, where we're making fast, instant decisions, leads us to make judgments about individuals without taking the time to really think about who this person is that's in front of us, or how all the stuff in our background, all the things we watch on TV, all the things we see on social media, the things we learned growing up impact how we see each and every individual that's standing in front of us. Mm-hmm. So, one of the things that I do in my work with my team, we're all responsible for doing our own implicit bias work. So how does my implicit bias function? Where are my personal blind spots? And what do I have to do to interrupt those blind spots? How can I be more open and have better vision, better seeing, understanding, and clarity about the person that's standing in front of me? The reason why I charge my team and I myself with that exercise is because it helps us to understand what works, and it helps us to understand how difficult it is to interrupt implicit bias and to sustain it over time. And so when we're armed with that kind of information, we're better able to relate to the people that we're trying to educate and that we're trying to bring along. We want every person, especially in the country, but then around the world, to be engaged in implicit bias interruption as a practice. So, yeah.
Okay, thank you. I look forward to March.
So it's settled that you will be back in March. We just have to pick which Thursday. Kalia Shaw.
When I come back in March, Amber, I'm going to talk about why I don't believe in love at first sight.
Oh, we can talk about that too. CED is all things, right? From people to infrastructure and everything in between. Kalia Shaw, she said thank you for the webinar, and that she had just learned via Ohio's employment law that implicit bias is deemed an unintentional action. Shoshonda Davis said, great information. Thank you. Dr. Prosper just was glad that he was invited to the session today. So just wanted to give you some of the comments that were in the chat. Now, Eric, you've been quiet today. I'm not used to that. So you want to have any comments or anything you like to make?
Oh no, just thank you. This is really important for all of us to learn and learn more about, and appreciate your work in this space. So important.
And then also, I'd like to connect you to an organization up in Dayton who is doing some work with the immigrant community and dealing with a lot of access and equity issues. And then also to a couple professors on campus who are working in that public health space. I think it would be some good synergy with the work that you're doing as potential, whether it's getting data, project, or what have you. But I just think it'd be good connections to make.
Oh, that sounds awesome.
And then Michelle had a question.
I had a question. I do not currently work in healthcare. I work in the philanthropic space that works with a lot of different nonprofits. So maybe community-based organizations that can support um, minimizing or finding solutions to like racial injustice and all these different disparities across sectors like healthcare. So my question is, after you've gathered all of this data and have done the research specifically with healthcare, one of the slides stated that healthcare disparities are driven by social and economic disparities. I think I saw that in one of the slides. So how do you use this data, and where are you using it at? Like, so if the issue is bridging the gap in social and economic areas of inequity, and that should like have this domino effect positively in the healthcare sector and with one's health and wellness. How are you presenting this data to start the process of filling in the gap where the gap exists?
Yeah, thanks for that question. So was that Michelle?
Kalia.
Kalia.
My name is Kalia.
Kalia. So Kalia, so there's the broad spectrum of disparities and types of disparities. And one type of disparities is disparity in care delivery. And so that's what we focus our attention on. I'll give you a couple of examples. So we've worked with providers that look at their diabetes data, and they see that let's say that their Latino patients have there's a disparity between their Latino patients and their other patient populations in terms of their diabetes being in control. So the next step so they've discovered the disparity. The next step in the process is for them to do a root cause analysis in an attempt to understand why the disparities are occurring. So is it because the patients say they have a large segment of their Latino population that that where English is a second language and they need their healthcare information in Spanish? Is it because they have a lack of access to medications? Is it something that they're not understanding in terms of the relationship that they have with their provider? Is there something that can be changed about that relationship? Do they need more education related to their to caring for their own diet for themselves in terms of their diabetes? So after doing that root cause analysis, we utilize the Institute for Healthcare Improvements methodology for testing interventions. So we use a Plan, Do, Study, Act cycle where the practice will choose to implement an intervention. Say, one of their interventions might be a process measure where they want to ensure that as many of these patients in the disparate population are getting hemoglobin A1C tests. So maybe, one of their outreaches might be as simple as making telephone calls to people in that patient population. Or it might be that they hire care navigators that go out and have conversations with the patients to understand more about, either why they're not accessing care, what's preventing them from accessing care, are they lost to care, but to get down to the patient level understanding of why this is happening, and then what they can potentially do to get the patient in for their HbA1c, and then start to work on interventions to bring that HbA1c number down. So that's one example of how we utilize the data. We can use a similar methodology, say, for improving vaccination, flu vaccine rates. we have an example of patient readmissions where we had in one city, we had for one health system, we had a disparity in Black men being readmitted for that had previously been admitted for heart failure and being readmitted for pneumonia. And pneumonia is a risk factor for heart failure patients passing away. So what they discovered was that their Black male patients were not wanting to take their pneumonia vaccine before they were released from the hospital. And so they learned further that the nursing staff in their conversations with Black men could do a better job of helping them understand why it was important for them to take that vaccine. And then also it was important for that population to understand that it was important for them to regain trust with the system that they were relying on for their heart failure care. So, the system was aware of, looking back at the history of discrimination in healthcare, that was probably impacting the decision making for their Black male patients. And so they were able to improve that vaccination rate, and that brought down the readmissions and ended up in a better outcome for their Black patients as well as for their nursing staff.
Okay,
Okay,
thank you for your answer. That was helpful.
I have one more question because I know we went over a little bit, but it's just such important and enriching information that you're giving. Shashonda Davis asks, how can we inform or advise people of color the importance of completing the demographics piece whenever they go to the hospital or clinics?
I'm going to say word of mouth.
Mm-hmm.
Word of mouth is one thing. Another thing is, so we have relied on a campaign from Robert Wood Johnson Foundation that's called We Ask Because We Care. And to this day, so we actually did this like 15 years ago, where all the systems in the Cincinnati region were utilizing this We Ask Because We Care campaign. So when you would go into a hospital, you would see a poster near registration that says, "We ask because we care," and then race, ethnicity, and language. So helping the patient to be prepared to understand that, oh, they're going to ask for my race and ethnicity, and associating it with better care. And then equipping registration staff to be able to explain a little bit further that we use this information to help us understand the care outcomes that groups of people are receiving at our hospital. And so we found that to be very successful. And then that campaign has been adopted by health systems across the country. So utilizing that kind of campaign is an important part of alerting patients. It's, generally speaking, people don't think about health care or what they're going to have to, the information they're going to have to provide or questions that they need to ask until they actually are in the situation and right there at registration. So I think a campaign in the environment is probably the best approach.
Is it anonymous? And if so, how do you show that it's actually anonymous when they collect that aspect of the data? Or does it help? Can it be used if it's anonymous in terms of those demographics?
It's not anonymous. When you say anonymous, help me understand what you mean.
Meaning that the person who is sharing, the ethnicity and sex and those things, that they don't have to have their name attached to it.
Oh, well, that's a really good question. So it is a part of the patient's medical record. So their name is, their race and ethnicity are included in the medical record. And what's important is for staff to be able to explain to patients if a patient asks, well, how are you going to use this information? It's really important for staff to be able, that's why we train staff so that they can actually respond to the patient if they ask that question. We have, a large Hispanic, Latino population in this country that are afraid to answer that question. And it's important that staff know, first of all, that we only use your healthcare information as needed on an as needed basis. And it doesn't leave this facility unless you've given us permission for your medical record to be shared with someone else. And second, if they ask specifically, I mean, there are Latino patients that will ask specifically, is this reported to ICE? And so, registration staff being prepared to say, no, this is not reported to anyone other than your healthcare provider. And then giving the patient the option to refuse to answer is important. And then once the organization has built trust with the patient, maybe on the next visit, the patient will be ready to share the information. So it's really being, sensitive and consumer centric in the approach.
And it's also about trust building.
Absolutely yes, absolutely.
So Shashonda, in the follow-up to her question that you had answered, that said, thank you for your response. She will start opening her mouth from now on.
Thank you. Appreciate that.
So once again, just want to tell you, thank you for joining us and giving us such insightful and practical information, right? And just kind of demystifying, that closed healthcare arena, because it's still kind of tight-lipped and closed, right?
Mm-hmm.
And so just helping us navigate through that. We look for you coming back in March. And do you have any closing comments that you'd like to give before we conclude today?
Oh, it's been a pleasure and a joy. I appreciate having the opportunity to be here and to talk with you. And, Amber, it's always good to see your smiling face and to meet Eric and Ambrose, and all the folks that were on the call.
Awesome.
Yeah, it's all good. I mean, of all the things that I have to do in a day, this is definitely a highlight.
That's awesome to know. Awesome to know. Well, this concludes our December 1st, 2022 edition of CED Office Hour Live, brought to you by the Community and Economic Development Team of Central State University and the Extension Department. Thank you. And until next week, we'll enjoy. If you missed any episodes, we put our past segments are archived on the Central State University Extension YouTube channel, so you can find them there. And reach out to Eric, Ambrose, or myself. I've put our contact information in the chat. You can reach out to us directly if you have any questions or comments. And until next time, till next Thursday at 2:00, enjoy the rest of your day.
Thank you.
Thank you.